All right, welcome. We're going to be doing a webinar series this morning for Club Physio on Neuro Fascial Mobilisation. We're going to share our screen and find our PowerPoint. Here we go. And we are going to go ahead and just enlarge this slideshow for us, play from the start, and we're set to go. So we're going to begin now. All right, welcome. My name is Stephen Goldstein, and I'm going to be your host, guide, and facilitator to talk to you today about neurofascial mobility, a webinar for the upcoming Club Physio workshop in Leicester on the first weekend of May 2018. So let's go ahead and launch into what we're talking about right now. The genesis of this workshop came about with my journey in understanding how to teach nerves when I was teaching massage therapy students in an advanced assessment course here in Australia. And at that time, when the course was taught, they were asked to conduct neural tension tests to provoke neural response as a special test. But the course didn't do was instruct the student in what to do next. They did not understand neural anatomy because it wasn't being instructed. They did not know about the biomechanics of neural motion. There were no techniques introduced to resolve neural tension, and that nerves under tension have an intimate relationship with tension in the other soft tissue structures, all the other tissue. So what I realized, like many others have sort of now including into their course curriculum or in other continuing education instructors around the world, Eric Dalton for one, and many others, they are now including neural tension as part of what you would do in treatment. So that's sort of the genesis for this. So what will you learn in this weekend? Well, revision of the myofascial arm line anatomy, because in order to work nerves, you still have to have a certain degree of compliance with the soft tissue. The soft tissue needs to still allow you to treat the nerves. And if the surrounding tissue, which the nerves affect and create tension in and of itself, if that tissue is way too constricted or tight, then you have to loosen that a bit. So we go through a little basic MFR and teach you a little bit about the arm lines for especially the upper extremities. We're going to do something called receptor enhancement theory and protocol, and that's the use of modified muscle energy technique to go ahead and use a very low load contract relax using the humerus or the femur to affect the lumbar or thoracic spine. And that allows when we want to do a slump test, if we want to do a forward bend, that just gives us a little more room for the spinal articulatory motion to be more compliant. We'll look at neural anatomy and definitely teach you very quickly, very simply, understanding the clinical biomechanics of the nerve, which is called the mechanical interface. And then the principles of neuromobilization include gliding and sliding. Now, in order to do this type of work, we really need to do some testing. And testing allows us to assess. And if anyone's familiar with my work or my instruction is we benchmark a lot of material. Benchmark means we do an assessment, we apply our technique, and then we go back and reassess so that we understand the direct relationship between the outcome of the intent and use of the technique. And this will be then applied pretty standardly. Many people have been exposed to these neurodynamic tests. They're often referred to as upper limb tension tests, but now they're more neurodynamic tension tests. And we will apply those simple ones to the brachial plexus, to the medium nerve, to the radial nerve, and to the ulnar nerve on the upper body. In the lower extremity, we'll go ahead and initiate a slump test and a straight leg raise test. And from there, then, we apply our technique and we go back to those positions. And those positions, these tests aren't just separate from your technique. They become just sort of integrated into how you use your technique. So it's really important to understand that you don't separate tests out of context of what you're doing. They're integrated into your technique. So these tests become more user-friendly. Obviously, the more you repeat a test, the greater experience you have with it. You begin to understand it, and it isn't as daunting or confusing when you're trying to apply it with, real time in a clinical setting. The pathways that we'll look at, if we can get through all this material in 2 days: sciatic nerve, tibial nerve, peroneal nerve, plantar nerve, femoral and obturator nerves. So, can we differentiate soft tissue? Is it possible to discern differing tensions caused by myofascia, muscle, and neural tension? And I believe the answer is yes. And to that end, this is how I instruct you. And so the benchmarking allows us to lift a leg, do a straight leg raise, differentiate a hamstring straight leg raise, differentiating a straight leg flexion, differentiating how the sciatic and the peripheral pathways of the sciatic create that tension. So we'll start to, very simply dissect the difference between when we lift a leg, what are we reading for, and what are we feeling as we do that. Now, obviously, the material came about because some real important people led the way with a lot of research, and I tip my hat to the physiotherapeutic community. In regards to physiotherapy, two of the main folks were David Butler and Michael Shacklock, and Shacklock's clinical neurodynamics is a tour de force. David Butler and the NOE group from South Africa, the work on pain science and neuroscience work that they do is extraordinary, and I suggest you have a squiz of what they're on about. But however, when it comes to technique, my attitude with technique is that I lean more towards the osteopathic methods and approach to applications on the body. Therefore, you'll understand the difference between direct and indirect work, especially regarding myofascia, but with specific with nerves. We'll be working over the pathway to facilitate change to the pathway. Sometimes we'll directly touch the nerve, but a lot of times we don't need to still affect it. And to that extent, Jean-Pierre Borel's work, The Manual Therapy of Peripheral Nerves, is a very important text. There are others, Diane Jacobs, the Neuromodulation group, and Berit Darkle, Somo Simple, will give you a tremendous amount of evidence-based approaches with the nerves. So what are we talking about, so that you have a basic understanding of what I'm going to present to you this first weekend in May. This will be neurodynamics. So clinical neurodynamics is essentially the clinical application of mechanics and physiology of the nervous system as it relates both to each other and the musculoskeletal system. This mechanical interface, which has been a terminology used by Michael Shacklock, states that the body is the container of the nervous system, and within the body, the musculoskeletal system is the mechanical interface to the nervous system. So MI consists of both the central and peripheral components. We're going to be looking at the peripheral components in particular. Peripherally, then, that's the nerve bed in which the limbs and torso, where the nerves are presented with bone, muscle, joint, fascia, and fibro-osseous tunnels, against which neural structures contract daily with daily movement and posture. The body or container moves, and therefore the interface must change its dimension, in which turn imposes forces on the neural structures. And this is what we're going to look at, because when my premise is, by the time, based on training, often people are dealing with nerves when they're quite dysfunctional. But if we can understand how to mobilize nerves as part of a larger picture, that when you do your muscle work and your myofascial work, whatever type of intent you have, then you can start to read the neural tension more clearly and just interface with it. There's some prime spots where you're always checking, just like you'd be checking for fascia. And that's the stuff, that's the material that I'm going to introduce to you. What's the primary function of a nerve? Well, that is basically to withstand tension. So they're meant to be elongated and shortened and to move. Another primary function is to glide longitudinally. So the nerve generally should move as you move, whether they call it an inert structure, but actually it's a very dynamic structure. So this nerve should be able to move as you move, and forward and bending, a number of arm movements. All that should accommodate, the nerve would accommodate it if it doesn't have a lot of tension. Another thing it has is the ability to be compressed. So it needs to be compressed because muscles are actively acting when you're doing volitional activities. So this is a very important factor in a mechanical function, the ability for it to compress. And of course, when it compresses, when the nerve itself is compressed upon, and it's no longer being healthy in that sense, or normal, maybe to use another term, that's when you start getting impingements and entrapments. So David Butler said the feel of a nerve is probably a peripheral nerve is a bit different. Nerves are pressurized and hard, harder than tendon, far harder than arteries, and almost have a slippery feel as their mesoneurial sheaths allow them to slip away from pressure. And due to internal pressure, they are rounded. The feel is related to the surrounding anatomy and depth of the nerve. And so David Butler talks a lot about the nature of nerves in his really seminal book in the year 2000 called The Sensitive Nervous System. But Burrell also talks about superficial nerve palpation. And so the medium nerve is one that we can often find. And we go where the nerve perforates the fascia, and we can move distal to proximal. And you're basically at the level of skin, and we'll teach you how to use this idea of where to palpate the nerve and how to feel it. We'll also review some of the anatomy trains model that Thomas Meyer has successfully produced for the world. Although science is saying some of these lines are accurate and some are not, I like the use of the arm lines because they give us some sort of collagenous continuity that takes in not only the myofascia, but takes in the bony joint structures. It takes in tendon. It takes in intermuscular septum, which is an area that really should be worked. And so we'll look at that in the class as well. Now, the use of indirect technique is really important. And so to that extent, I'm going to teach you one of the hallmarks of fascial therapy, a method that I teach, of which neurofascial mobility or mobilization is part of, is called receptor enhancement. And this term came from Eric Dalton years ago, and I sort of co-opted the name and sort of spinned it a little differently than he was working with it. But at the heart of it is you're using low force muscle energy technique to go ahead and create change using a levering. And so the humerus will affect using arm levers to go ahead and affect the thoracic spine when we pair them up. And the same can occur with the lumbar spine. So this use allows us to go ahead and affect these articular mechanical receptors in the spine to relax a little so that we can get compliant movement for our testing and our treatment. This is an example of a position bilaterally where we use call it the prayer position, and we do a series of flexion, extension, abduction, adduction movements. So the arms are like this. You're going down and up. You're going boop, boop, squeeze and pull apart. And then normally what happens is then that relaxes down. We also do a long lever one as well, and you can see. So we just do a pairedness of pushing in the various directions that move the spinal segments. And often you get a dramatic change to the scapula and the ability to especially horizontally bring your arms together and apart. Then we'll be proceeding to look at the brachial plexus. So the brachial plexus is a tougher area to work. This is what a lot of the situations with thoracic outlet. And so we're going to look at technique and teach you how to grasp that neck and try to get some movement out of that area, and the cording that also goes down in through here. So this is a very, very important area, and we know our scalene and pec minor tightness can play havoc with that thoracic outlet. So can we get that area to relax quickly? Well, if we target and intend to work the plexus itself, yes. The answer is yes. We can get change to it. We'll do neurodynamic testing, and basically just a shoulder depression and moving the head to the side is your basic plexus test. So it makes it simple. If you can't depress a shoulder and you think it's just trap, you may actually find its brachial plexus is tight. Then we'll teach you what's called grasping the grip and getting the grip, how to hold that neck and go ahead and use a series of techniques with the arm, with the lower or the hand. You see that there's just glimpsing it on the serratus anterior rib cage as we move that shoulder along with the neck work. You must do something. You can't just purely work neck. You must bring your shoulder and humerus, the scapula, into play as you transit around that thorax. So it's a more complex area to make sense of, but it certainly can be very accessible and can get some dramatic change. In order to do this, in all my workshops, I teach what's called an ease-bind relationship. And so we learned to read and assess the surface palpation along with an ease-bind motion palpation assessment. They're very simple. Once you master them, you just sort of apply them all over the body, really. And they work very, very well. This ease-bind is then put into what is called a stacking assessment. So you're gathering at least 3 planes of distortion, 3 directions, 3 surface areas, and we teach you how to do that in paired hands and single hands to stack this tissue and then go ahead and try to facilitate a change. So the tension stacking is one of the terms that we work with, and that I'll teach you in the class. Then we move down to the medium nerve, and we look at the anatomy of the medium nerve, and we always will do the upper limb neurodynamic tests, and these just become part and parcel of a movement pattern to look at the nerve, and all these steps are included. This has been played out endlessly on your YouTube, so all this material is very accessible to you after the class, because the eminent domain, everyone tends to be using these. But if it's your first time using them, then we get a chance, or even if you're a veteran, we get a chance to really look at just practicing this and using it, making it sort of just one of the movement patterns that you always assess. If you're taking an arm and going through range of motion for a shoulder, why wouldn't you also do your limb tests? If there's any numbness or tingling, pins and needles, that sort of thing, well then boom, you're off to use these type of neurodynamic testings. Then we'll look at where the medium nerve is. We'll look at something called where the nerve, normally you catch the medium nerve at the carpal tunnel, but you can also catch it as it threads through the pronator teres, and that's called pronator syndrome. So we'll look at a few other syndromes that are associated with the pathway, the journey of the muscle through the peripheral body, and carpal tunnel, of course, is one, so we'll touch on carpal tunnel. We'll look at how we do some of the technique, and teach you how to do the simple version of the technique, and then we'll bring in gliding and sliding motions. We'll teach you the movement to not only for yourself, but to take something home for your clients. We go then through radial nerve, and we do the same thing. We just walk through that pathway. We look at the structure of the radial nerve. We put it in its test. We realize that there are obviously syndromes associated with that neural pathway. This one's called radial tunnel syndrome, and a posterior interosseous nerve is affected. We can look at the distribution of where the nerve goes, and this gives you a reading in terms of assessment if that presentation is happening. And then we apply treatment to that radial nerve pathway. The triangular space is a very important space to work. We move down the line, and then we move again into gliding instructions and what also is termed as flossing. So we move to the ulnar nerve, and again we run through our ulnar nerve bias. And we look at, again, now what's called the cubital tunnel. So these become just sort of where the nerves really tend to get affected. These syndromes are the places where there's either the nerve is more on the surface or repetitive motions will cause stress to that structure and inflammatory processes that start to make the nerve unhappy. We go ahead and we do these basic motions. And my premise then is once the nerve is relaxed, these movements are restored. So it's a really quick benchmark for us to utilize. And then finally, moving into day 2, along with the material in day 1, we move into the lumbar and sacral plexuses. So as we move through there, we understand that the mechanical interface for the spine is that you can move 5 to 9 centimeters. That spine is meant to move. So what we find with a lot of folks, like folks like myself who is older, that the spine is not as flexible because we haven't been doing what we ought to be doing through life, which is creating a lot of spinal motion using core-based programs like Pilates offers or yoga, the Feldenkrais methods, where we're keeping our spine flexible. So a lot of the folks you see that you try to do a slump or SLR, it's just partly because all that structure has been congested, and along with that, the normal motion should be quite easy and free. The spinal cord should move. There are fixated points that we'll look at, and that's where we can intervene. But generally, that spine should have some great movement. So when we look at the postulated biomechanics, it's important to realize the tension on these points depends on the position of the extremity. And so there's particular points that we'll look at and we'll work with. The Slump Test is a major test that we want to utilize. And so each of these positions for the slump are utilized. And we will go ahead and work with each of those as we take them through the slump. I also have to do some preparation for the neural treatment. So we'll look at the low extremity, the superficial backline, and we'll bring in some quick work that is usually in greater detail in my myofascial classes on the muscle fascial ligament muscle interface of that area of the posterior superficial backline. And I'll teach you a ligament, sacrotuberous ligament technique if you don't know it, just to get that so we can do a straight leg raise to accurately read it. So sometimes the preparation has to be done so that we can go ahead and work the nerves. You can't just, on some folks, just go straight to the neural work. There has to be some preparation, and so we have to understand that. We can do a couple of surface techniques I can teach you on top of the gluteus and teach you what's called a glide fulcrum. We can go ahead and do some skin rolling if necessary on the back. So these are all very basic, quick techniques. You could put these into play in less than 3 to 5 minutes and be ready to prep into a longer neural treatment. Then we move to our SLR, the straight leg raise, and from that then we'll differentiate what the normal response is when you lift a leg and where the range should be and what you're looking for. And it's just good. You have a better understanding of what you're looking for when you lift a leg. Then we'll pick our orientation spots for where we prepare our technique. This work came from J.P. Burrell. And so we look at those spots. And then we slide down that pathway and we start working it. We start in a longitudinal direction at some key areas. And then later we apply the second motion pattern that nerves should have, which is a transverse plane. And then we have to coordinate both surface movement with joint movement. And we do this in a one-directional manner. And once you get it, you sort of then really, you're using the same technique all over the body as you understand the neural anatomy, and you're guided through just the confidence that you need to get to apply this technique on your own. And that's what the 2 days are about. Then we sequence through. I'll teach you some a knee joint, a quick knee joint maneuver, which is a special test called Apley's compression distraction. That's usually used to assess for ligament or meniscus pain. But the pump motion of just doing that allows the capsule receptors to respond and relax. And often that helps the sciatic nerve, especially at that popliteal fossa. Likewise, we need to do something with the ankle. So we'll mobilize the talus and look at the calcaneus a bit, and then we'll move into our tarsal tunnels and our plantar nerves, etc. We'll learn what's called the tibial neurodynamic test, TNT, and that's just for the tibial nerve. It's a simple maneuver. You'll learn that. We'll treat the tarsal tunnel, which is a very sensitive medial ankle aspect, and will be sore in everyone usually, and try to get that at that particular junction to get that to move. And so that's a neuromobilization spot. Then we'll work plantar nerves, which is synonymous often with what's called Morton's neuroma. We'll look at the plantar nerve, and then we'll finish the course with the last two techniques, which will be obturator and ephemeral nerve for the plexus. That's obviously the most sensitive area because it's the anterior femoral triangle and the groin area. So you're very close to the pubis and the genital region. So we'll just set up a protocol that make it so that you feel comfortable and your client feels comfortable in assessing that area. So finally, this course, besides being at Leicester with Craig and the Club Physio sponsorship, will also be presented just a little snippet for an hour and a half of this on the sciatic pathway at the British Fossil Symposium a week later in Solihull outside of Birmingham. So I thank you for your time. Hopefully this will be a teaser to get you into the class and learn how to treat nerves and get excited about another skill set that you can be able to offer. So I thank you very much, and that will conclude our presentation for the day. I wish you well and look forward to meeting you sometime in the future. My name is Stephen Goldstein again, and thank you.